Welcome, everybody, and thanks for joining us again for this the second panel discussion in the series of attempts to dive into the sources and perhaps even some solutions for challenges related to health equity that are confronted in cancer medicine and medicine at large. Last time, as you recall, we focused on access to care. This time we're going to focus on social determinants of health. And let me welcome our panel again, depending on how the Hollywood scares are organized in your viewer. We have Ashwani Rajput, a surgeon and the director of the Kimmel Cancer Center footprint in the National Capital Region. We have Akila Viswanathan, the director of our Department of Radiation Oncology and Molecular Radiation Sciences, and Otis Brawley, a Bloomberg Distinguished Professor of Medical Oncologists like me, and the Director of Community Outreach and Engagement for the Kimmel Cancer Center. So I'll start with just a couple of facts that I found interesting we're able to find. First, the Centers for Disease Control and Prevention, the CDC, defines the social determinants of health as, quote, the conditions and the places where people live, learn, work, and play. In other words, their life footprint in a way. And poverty is definitely one of those things that we know colors access to healthcare and healthcare quality throughout the world, but certainly also right here in Maryland. And interestingly enough, Maryland happens to be better off than many states in the United States. Maryland has about a 19% higher poverty rate. That's 200,000 more people living in poverty than it did in 1990, which was the year of a recession. It's now up to 576,000, 77,000 people living in poverty by the formal definitions by our federal government. Median income in Maryland is $76,000. If you look at the child poverty rate, it's 13.3%. Senior poverty rate, remember, cancer is the disease that disproportionately strikes people as they get older. That's 7.7%, and that is defined as $11,800 salary per year for an individual. So 8% of seniors in Maryland live below that poverty rate. African Americans, 15% of them or so are below the poverty rate. Hispanic, Latinx folks, 14% below the poverty rate. If you're a woman who's the head of a household, 19% living below the poverty rate. The housing wage, there's an estimate that in Maryland you need to make about $28.27 per hour in an hourly wage job to be able to afford rent and utilities without spending more than 30% of your income. And the other side of it, direct to medicine, 24% of Marylanders get their health care under Medicaid. 8% of them, despite the Affordable Care Act and other maneuvers, remain uninsured. So we go around the horn here and start with Ash Rajput. As a surgical oncologist, you very often see people right at the beginning of a cancer diagnosis, particularly of localized disease, and you evaluate them and you try to begin the construction of the treatment plan that may involve local therapy. How does poverty influence, how does it color what you see? How does it influence the decisions that you make?
Well, it clearly does. In fact, Dr. Nelson, and one of the things that you hope for is that the person is going to come at an early stage of disease. And what we've seen is sometimes the people who are living in poverty don't always have access to screening so that they're diagnosed at an earlier stage of disease. And so that colors how they're treated as well. The other thing that I would say, and I would just give you an example from my practice, is that I had a patient who once presented with an isolated lesion to the liver that was a metastasis from a prior treated colorectal cancer. And that patient was set up to go on and get more imaging, and he disappeared. He never came back. And he came back almost 8 to 10 months later, and at that time there was extensive disease in the liver. And when I talked to him about what happened and why he didn't come back, he had a $150 copay for his MRI, and he had to make the decision between getting a cataract surgery, which was also a $150 copay, and he wanted to be able to see, and he thought that was more important than going to get his treatment for his cancer in his liver. So clearly that poverty does impact people's decision making and what they're going to do for their day-to-day life and not always survival.
And so, Akila, by the way, for those of you who are in attendance, you may have a question may bubble up. Please enter the questions in the little Q&A. You can click on the Q&A spot and enter the questions, and we have somebody that will watch them. And at the end, we'll try and get to as many of the questions as we can. But Akila, as a radiation oncologist, particularly one who works hard to take care of, for instance, younger women with cancer of the uterine cervix, these kinds of illnesses, radiation obviously is a high-priced deal, but it's also one that people have to come back and forth frequently. Little things like bus fare become a major lift, I think, for people. How have you seen poverty impact what you need to do and how you need to help people that you see?
There are so many antecedent reasons why people develop cancers in the gynecologic tract, and cervical cancer. A lot of it has to do with lifestyle, tobacco use, alcohol use, drug use. These are all related. We've had, I had a patient who lives about 3 miles away from the hospital in Baltimore and came into the ER at Bayview, which was literally around the corner from where she lived. She could not get transportation or funding on her own to come to Baltimore for radiation. That's how difficult it was for her. She didn't have a car, she didn't have bus fare. We were able to help, obviously significantly, but even a cell phone in order to send reminders of appointments and things, because she didn't really have very stable housing or very stable, support systems, all were challenging to receive care. And that is unfortunately the state for many patients that have cervical cancer. The reasons for it are complex social ones, but it is a preventable disease if people get vaccinated early enough in life. And so even just having this type of virally induced cancer that can be caught early is a symptom of these social sequelae from their lives and lives in poverty.
Well, Otis Brawley, you and I over the years have talked many times about the ravages of poverty and how they often appear in guises that look like inequities associated with race, ethnicity. Many of them are anchored in poverty. In fact, as the sort of a working problem. There may be reasons for the poverty that are anchored in race and ethnicity, but poverty seems to be really quite undermining. And I remember talking with you a few years ago about a sort of a robustness that you don't have if you're trying to make do in poverty, that one additional thing might push you over the edge. You don't have that fail-safe system. And we've just seen one of them with COVID-19. The economic impact on people who are already poor has been substantial. I'm kidding you earlier. The University of Chicago, a place that you know and love quite well, did a study that really I found quite fascinating. They estimate that the number of people living in poverty in the United States grew by 6 million people just as a consequence of the initial phases of the COVID-19 pandemic. What about poverty from your perspective?
Yeah, Sam Broder from the old director of the National Cancer Institute was very fond of saying poverty is a carcinogen. And it is. It really leads to lifestyle and exposures that cause a lot of cancer, number one. Number two, very important what you said there, it is really poverty is more so than race, because one of the things I did was calculate the disparate population in the United States in terms of cancer. And it's majority white, usually poor, many in Appalachia. It's primarily in the South. Interestingly, it's more in states that have not expanded Medicaid under the Affordable Care Act versus states that have. But it is, of course, blacks and it is Hispanics, but it's more white than anything else. All of them having poverty in common.
Well, you raised one other aspect, and we talked a little bit about this in the last set of discussions, which are there's poverty and then there's the rural poor. The rural poor often are far away from healthcare facilities, far away from educational facilities and the like. They have their own unique challenges. One of the things I thought we could dive in a little bit is, you turned me on to this, Otis, but I'll turn to Ash first, and that is, there's a growing, if you look at some of the foundational risks for various chronic illnesses in the United States. They're all converging on a core set of them, in which people become overweight with poorly controlled blood pressure and blood sugar. And that general phenotype increases their risk for cardiovascular diseases, for kidney disease, for cancer, et cetera. But one of the challenges in that to eating well and physical exertion is this concept of a food desert. So the notion of a food desert, it's an area where residents need to travel, an excessive distance to reach a supermarket, and these are people often that don't have automobiles. So that kind of travel is not going to happen. But if you look at Baltimore City, which is an area with significant food deserts, the median household income is at or below at least 185% of the federal population for the whole city. And so 30% of everyone in Baltimore City lacks access to a car. So the supply of healthy food is quite low. Even if they wanted to have healthy food, it's very hard to come back in a place like Baltimore. So when you look at something like that, start with Ash again, many people we are accustomed to with a cancer diagnosis will come, they'll visit their surgeon, radiation oncologist. One of the first questions out of their mouth is, should I change my diet? What should I eat? Was there something about my diet that affected, cancers? The diet, what do you see with the diet?
Yeah, so that's really important. But one of the things that happens, and someone comes to talk about when they have a diagnosis, often that, and I've talked to Dr. Brawley about this, is that something that maybe should have happened 20, 30, 40 years ago. And so that's why it's so important to have this education in our schools and starting with our young people, that we inform them of the importance of this diet. So really at that point in time of the diagnosis, you can have these somewhat discussions that could be more academic with them, but then moving forward for maybe the secondary prevention is a more important discussion. But also to your point of the desert health, the food desert, and maybe the distance to care for a region, then you also talked about the city, right? So from a rural perspective, they may have to travel to get to a grocery store, but they may have access to those fresh fruits and vegetables. But as you were talking about Baltimore City, I was also thinking about Washington, D.C. And if we go on the district's Department of Health's webpage, you can superimpose where healthcare facilities are and where also grocery stores are. And so there seems to be a real desert for grocery stores east of the river in our Ward 7 and 8, even though there may be transportation available publicly, whether there be buses or subways, we still don't have those facilities for people to buy those fresh fruits and vegetables that are so important in terms of cancer prevention.
And there's pretty good evidence, as you turn to Akila, there's pretty good evidence that these neighborhoods, you look at different neighborhoods in cities, the neighborhoods that are sort of characterized as food deserts they're also underrepresented healthcare access. And they clearly have, literally neighborhood to neighborhood, higher rates of diseases that are linked to unhealthy diets, including cardiovascular disease, diabetes, and cancer. Many of these kinds of cancers, we've got use of breast cancer, one of them related to diet, colorectal cancer related to diet. When you see these, Akila, how do you think about these in terms of risk? And the diet is one of the great modifiable risk factors. There's every belief that if you can modify the diet moving forward, that your survivorship will be improved, whether it's by limiting other disease risks or by, in fact, reducing cancer recurrence. That's for somebody to figure out in a clinical trial. But you know what I'm saying is, as you counsel people, you would love to counsel them in a survivorship mode. You're going to cure a bunch of people with radiation oncology, radiation therapy. But when they can't deliver, how do you approach that?
So diet's obviously critical, and I just want to repeat and reiterate the importance of what you're saying, and kind of put it in context. I remember being at a med school in New York and had come bringing an apple for breakfast that I had paid 45 cents for downtown next to a nice hotel, and had come up and literally was in a poor part of the city, and the exact same piece of fruit was 3 times the cost. I would have paid $1.05 for the same piece of fruit in the poorest part of the town. And for people who can't travel because they're not taking the subway or a cab or, driving themselves, they're paying that $1.05 for an apple. And this was a long time ago. So, there's a lot of price inflation in these food deserts, and people are forced to buy, whatever is the least expensive thing, which oftentimes is the fattiest, highest sugar content, worst food that one could find. So, I've seen kids in these neighborhoods carrying potato chips for breakfast because they know, the mothers know that that's at least 150 calories, and it's $1. Rather than, the eggs and bacon or whatever the cereal and things that might be more, but are healthier because they're fortified or they're just more nutritious. So, I think the influence of food on society and obesity, diabetes, and cancer can't be underemphasized. In women's cancers, uterine cancer is a directly linked to obesity. So the fatter a woman is, the higher the estrogen production that occurs, and the higher the risk of uterine cancer. So we know that if women are persistently obese after even a diagnosis, their risk of recurrence is higher. So everything we can do to help. But again, it also brings up the whole topic of what we call financial toxicity, right? So patients don't have the funds and they don't have the access. So how are we going to help them get the right diet through treatment, where we do give patients a very specific diet to prevent side effects? If they can't afford the meds, they can't afford the diet. We try to provide nutrition for them. We do, we have funds that we try to collect for in order to help support the grocery bill for our patients, to support their nutrition to get through treatment. But it's not easy, and I think these are some of the major unanswered questions that society has to address.
So Otis, you were one of the first of the cancer researchers I can remember talking a lot about these food deserts and what that really meant. In Baltimore, 1 of 4 residents live in what is believed to formerly be a food desert. This is from the Johns Hopkins Center for a Livable Future and the Baltimore Food Policy Initiative. 34% of African Americans food deserts, compared to only 8% of the Caucasian residents, and 30% of children. You focus on this, the lifestyle change we want to affect is in children who are going to grow up to be adults. 30% of children, school-age children, in these food deserts.
Yes, absolutely. Important to this conversation, 33% of all cancers are due to smoking. That's preventable. 30% are due to the combination of obesity, consumption of too many calories, and not enough exercise. Think of it as a 3-legged stool. We call it energy balance. That's 30% of all cancers. Many people don't realize 12 different cancers. As Akila said, uterine is number 1, but also breast, also colon, also prostate. 12 different cancers are linked to the energy balance thing. We're dealing with, in Baltimore, 65% of Black women are obese. It's another 20 to 25% are overweight. It's a socioeconomic thing. The dollar store, common place to buy food in Baltimore because there are no grocery stores. Part of the logistical business plan of the dollar store is canned and preserved foods. High carbohydrate foods are cheaper and easier to store compared to groceries. The National Cancer Institute, FDA, and USDA have recommended a simple thing: 5 to 9 servings of fruits and vegetables per day in everybody's diet. It pushes out all the bad things with satiety and so forth. It prevents some cancers, prevents diabetes, prevents cardiovascular disease, attacks all the chronic diseases. Hard to do 5 to 9 servings of fruits and vegetables per day if you live in a food desert like Baltimore or Ward 7 and 8 in Washington, D.C.
I can remember maybe a decade or a decade and a half ago hearing ex-President Bill Clinton talk about one of the great successes in agriculture and the food service industry has been the distribution of calories around the planet. Calories, but they're not distributing nutrients around the planet. And and argued that we should somehow figure out a way to enable these conduits that can deliver calories to so many places to better deliver nutrients. And I would hope. But
Well said.
another thing to credit President Clinton, he was the one that said it. Another one that has come up a lot, and there's been a lot of exploration of all aspects of this, from physiologic studies. What's the consequence of stress on the physiology and physiologic adaptations to stress? But so what is stress and how you can measure it? There's many different views of it and how to ponder it. But there was one group that looked at 30 sort of metrics in different cities. They looked at the weekly work hours, the suicide rate, the debt load as it distributed across the population, and many, many other things, amount of gun violence, crime, et cetera. And from the U.S. Bureau of Labor Statistics, the CDC, et cetera, Baltimore ends up being the 11th most stressful place to live in the United States. By the way, Newark was the #1, Detroit, Cleveland, Jackson, Mississippi, Miami, Birmingham, I'm reading them off for you, San Bernardino, California, who knew, Rochester, New York, Augusta, Georgia, Shreveport, Indiana, up ahead of us on this list that you don't want to be on. Do you see, evaluate, and perceive stress? We have stress screening tools that we use when people come visit us. They're a screening tool. They're not a diagnostic tool. What's your perception of stress and the way it's distributed across who we see? Are there differences, disparities, inequities in stress that you see among cancer patients and their families, Ash?
Absolutely, and you're right. And so organizations like the NCCN, the National Comprehensive Cancer Network, provide us with these calculators to look at distress and maybe make a red flag for us to get our mental health colleagues involved to assist the patients, whether it starts with social work or ultimately psychiatry. But it clearly does play a role, and we've even looked at, just the fact of hearing the diagnosis of a cancer results in the stress. And then once we get the patient through the treatment, there's also the financial implications of getting the treatment. And then what are the financial stressors that also impact the patient? So it's clearly an area where I think maybe warrants more research, but from the basic science side of things, we know that stress has an impact on the immune system as well. So how might that play a role in their treatment and the success of their treatment? So clearly an area that we need to focus on.
So Akila, the grand rounds discussion today was Tom Gajewski from University of Chicago again. Who was one of the folks who's explored this business of how the microbiome in the gut, right, can influence how effective the new immunotherapy drugs might be. And as they've chased this down ever more mechanistically, one of the things they're beginning to discover is that in a certain microbiome in the gut, there results in adaptation related to the various cells that are there, macrophages, immune cells, and the like, and that these cells can travel to other parts of the body, and they may, in fact, be responsible for making obesity worse, making cancer worse, et cetera, et cetera. When you see stress as a cofactor in developing the disease, you need to encounter stress as a, something that might undermine a very technically sophisticated course of radiation therapy, where you need compliance and there may be symptoms that you need to work through. How do you see stress compromising cancer treatment and its execution?
Wonderful analogies too with the microbiome there. The first thing when we see a patient, I would say 9 times out of 10, you have to ask and you'll find that there's a stressful life event that preceded the diagnosis. So it's not always, and it's not always obvious, but in a lot of women with breast cancer, patients that I see, it's not just lifestyle. There is a stressful component where, just to your point about the immune system has somehow, not kept up its guard. And as a result, you have a new diagnosis. And so we're already dealing with patients who are coming in not necessarily at the peak of their immune strength, their fitness. And I think that the course of treatments, of course, that we give can compromise that immune system further, but in a slightly different way. I think that trying to balance during the course of treatment that strength through, what we were talking about, the diet and how people eat regular meals, make sure they have enough protein in their diet, ensure that they're well hydrated. All these are important, but the mental component of being diagnosed with cancer, but before cancer is diagnosed, there was a stressful event. So ensuring that we ask the question and understand what happened, was there something that happened, and then get the appropriate resources together to help that person address that stressful life event. Not just the cancer itself, but the entire picture of that person's stress in their life. Whether that be through nursing, through social work, through other resources, we try to put together, there's some integrative medicine programs with yoga, therapy, through other resources that might help with stress depending on that person's need.
So as we talked a little bit about some of these inequities, they're anchored a little bit in sort of there's no reserve. So in poverty, people are getting by somewhat, but a cancer diagnosis challenges their financial circumstances in devastating ways. Receiving cancer diagnosis, most people tell you is one of the most stressful things that can ever happen, but we have people who are already under significant stress with very little reserve, again, pushing them over the edge. How do you think about stress as a cofactor in cancer, a cofactor in poor cancer treatment outcomes and the like?
Yeah, well, you just mentioned stress in Baltimore, for example. A lot of people, especially poor people, especially less educated people, they medicate their stress with smoking, or they medicate their stress with drinking, which is another cause of cancer, or they medicate their stress with eating, binge eating, which leads to the obesity and other things, the diabetes, as well as cardiovascular disease, as well as cancer.
Some people have used that as
really need to take.
I was going to say, some people, you're talking about Appalachia and other places, some people have argued that stress is responsible in small part, at least, for the OxyContin epidemic as well. So.
Absolutely, absolutely. And we really need to start being more holistic as we think about people. Community outreach and engagement in the Cancer Center really is holistic in that we're not just trying to prevent cancer, we're trying to promote health. And promoting health means someone living a long life without illness, to include diabetes, addiction, and other things.
So promoting health by somehow promoting a healthy lifestyle, which is going to include things other than what people can directly control. You'd hope they could directly control it, but if they don't have access to the right resources around the town. Now, Otis made a point, Ash, that's always a very interesting one, related to education. So there's a concept of health literacy. I mean, people have a better sense that they need to be followed carefully if their blood sugar is going up and down or whatnot, and other people don't understand why they need to be followed in this way. And some people have worried that education itself and health literacy limit the way people approach health promotion from medical care, right? Screening and early detection and the like. What are your thoughts about health literacy? Health literacy also, cancer's got to be one of the most complicated things to describe a treatment plan for. Cancer patients, no matter what a walk of life they come from, they're the smartest people ever if they can get through cancer treatment, because it's not easy what we ask them to do along with us. So what is your view of health literacy? How do you see that differently in different people? There's language barriers, there's education barriers, there's all kinds of barriers to people being better engaged with their healthcare.
Yeah, that's so important, and as physicians, how do you present that information to the patient? And so I think, there's this whole area, and I think we're going to talk about it in our next section, but touching on the diversity of the workforce, right? So does the physician understand the community? And so one of the things that we're looking at is really to serve the community, really understand the needs of the community. And so we're also working on getting some community advisory groups in DC together so that we can go into the community with educating ourselves to meet their needs, and then present that in a way that they understand that. So at a certain level, and not always talking in the science or the doctor speak, but in simple language for certain people to be able to understand it. And then also using interpreters for those people who speak different languages so that they can understand it. I read something recently that, and this was specifically for African American men, that they would be more likely to follow certain guidelines if they had an African American physician giving that to them. And it was something that was presented at a surgical grand rounds recently by our chief of surgical oncology. So those are the type of things that I think we really need to be aware of, is speaking the language so that people understand and trust the provider to follow those guidelines.
So you're arguing in a sense that health literacy has two components. There's patient literacy or personal literacy, but also provider literacy. Does the provider understand the stresses, the educational challenges, and the needs of people in the community so that they can listen better and be more attentive to these issues?
Exactly.
Akila had a slightly different direction of this. So there had been an argument many years ago that when someone would come with lower health literacy, that physicians would select a different treatment because they said, cancer treatment is so complicated and so difficult. I'm not sure this person can get it or can come back at the right time on the right day and all this kind of stuff. So I'm going to give a treatment that I know is slightly less optimal, but I think it's safer to give, or some logic of this. It goes under this sort of provider bias. Is there something you see or physicians see when someone comes in that they might respond to incorrectly with a bias that's not a choice? It's I've decided, I made a choice for them because I think this will be easier to pull off.
Absolutely. And it has to do with then ultimately their survival from cancer. So I'm going to give you two examples. I'll never forget the first time I had a patient who had to use her thumb to sign. And I remember it. And she asked if she would make a cross or use a thumbprint because she'd never been taught how to write. And I think that what I try to teach people that work with me is, and this is going on to personal literacy, but I think you cannot assume what someone understands, nor can you assume that the methods by which we normally communicate are understood. That includes the written word. When I first went to the African American Museum in Washington, D.C., the person who was next to me said she was so grateful that everything was auditory, that she could listen to everything because she could not read the writings. And in fact, she asked me, was everything that was being said actually what was written? And I told her it absolutely was. And that it made it clear to me that it was intentional, because people are not necessarily trained to read in their early childhood, depending on their circumstances. And so language, the written word, we take it so for granted, but the auditory word is incredibly powerful. And we need to remember that when we talk to people, that they remember what we say, because that may be the only way that they're understanding what's happening to them. So I give that as an example just to say, the perception that we all have about health literacy is imbued with our own experiences and our own interpretation of the world. I do think that patients are sometimes very hesitant to express to them their language skills in terms of another language that's not English, or that our team may not be aware. We've created obviously great systems to help with that, but then even just the complexity. So I treat women curatively using a combination of two different types of radiation. One of those types of radiation requires procedures that are done under anesthesia in an operating room environment. A lot of people in the United States deserve both treatments for cure, but we know statistically that over a third of women that qualify for that treatment don't get it if they're in a situation of economic distress, live in an environment where they may not have great access. And so they don't receive what's considered absolutely standard of care. That's been the standard of care for 100 years. Like, we know it works. It should be fine. Everybody should get it. And the main reason is, again, what you're talking about, health literacy. People don't want to explain to people. They don't want to put the stress on them of getting it. It's effort, it's work, it's hard, it's a procedure. And so people end up having a recurrence or a death from disease. So really important points.
So Otis, one of the ideals of the highest quality care is this notion of informed consent, that we would describe the nature of the disease, the strategy of the treatment in a way that the person understands it, who can make a choice. And by the way, if we were talking about a clinical trial, then if anything, it's informed consent on steroids. We want them to understand every aspect about the potential risks and benefit. And yet many of these devices that we have, these aids that we have to help out, some of them are pretty good. They're films and whatnot, variably culturally sensitive, et cetera. But many of them just seem to have all this fine print on them that I don't understand. I don't know how anybody does. What is your perspective? Are we delivering informed consent to everybody that we need to, economically, race, ethnicity, national origin-wise, et cetera?
We are not. We are not. And very astute point. When I became head of the cancer center at Grady Hospital down in Atlanta 20 years ago, one of the nurses there told me, always keep in mind that 40% of the patients here can't read. I was kind of stupid. I'd just gotten bifocals, and she said, no, they can't read. And that leads us to the point that many of us in medicine worry that our patients don't trust us. We need to worry more about being trustworthy. We have to be willing to sit down and explain, talk, and communicate to the patients. And when it comes to literacy, in the 1990s, I did a series of studies because so many people thought there was a difference in black-white biology, and that was the reason for the disparities. I went to the military. I looked at military retirees who were treated in military hospitals, and I showed that black equals white. Equal treatment yields equal outcome among equal patients. And then another nurse came and explained to me something I should always remember. Yes, black women do well in the military hospitals, and it's not just access to care, high quality care. It's the ability to utilize that care. It was pointed out, I may be studying a black woman who has access to the military hospitals because her husband did 20 years in the service and retired 20 years earlier. Her sister, who might live in Southeast Washington, when she goes to a hospital, not having had those social experiences, that sister is intimidated by the big building, has more difficulty finding her way through the hospital or clinic to the clinic that she needs to go to, and even has more difficulty dealing with the clerk behind the desk to get the health care that she needs. These are all healthcare literacy issues, not to mention adherence to the prescribed therapies, just being able to take pills twice a day as prescribed. So those are all issues. They have to do, again, with poverty, with social determinants, to include just being aware and able to get along in a complicated hospital system that, quite honestly, I sometimes have difficulty getting along, finding my way through Hopkins.
So I guess we take one more around the circuit and moving forward. I can remember having a long conversation once that was very illuminating with Marion Rice, one of the leaders at one of the historically black medical colleges, actually more than one in her career. And she was describing efforts at American medical schools to incorporate cultural competence training, health literacy training, and these kind of things routinely, not as a, but routinely into medical school education, recognizing that our society was going to progressively become more and more diverse. And our physicians, as all of you have mentioned, need to become more trustworthy and more able to listen and garner these insights in the many different people we'll take care of. Do you see that happening, Ash, in surgical training and in medical school training? Um,
Absolutely. So this whole question about diversity, and inclusion and equity, and things have changed even since I was in medical school in the last century. And a very personal anecdote, what I'll tell you is, as a fourth-year student doing my sub-I on the surgery service, I was pulled over by the chairman, and I was told that since I was expecting to go into academic surgery, that I should know I would not have a lot of opportunities in American surgery because of my name, and I should just face that reality. And then he walked away. And so, I was got a ton of bricks put on a young medical student looking to the future. And I think, what we're doing at Hopkins and what other institutions and medical schools are doing is this some very serious discussions, and sometimes can be some very painful discussions in terms of acknowledging what's happened in the past, acknowledge what's going on now and what the future is. And so having these conversations with our faculty, our staff, our trainees, and really to get staff to understand what their inherent biases may be and to face those, and that way we can make a change. But I do think it is changing and for the better, but we can't stop yet because we're not there.
so Akila, you're responsible for training of radiation oncology physicians and radiation physicists, one of the key elements in radiation therapy, both at obviously at Hopkins, but also contributing to nationally other trained. How is that changing, do you see, in response to the need for diversity, cultural competence education, and the like?
So radiation oncology has not historically had a lot of diversity in the field. It's been a very traditional field, but we are expanding inclusion by efforts. So one of our faculty, Dr. Kurt DeVille, is heavily involved in ASTRO, our national organization, in order to build committees that deal with equity, diversity, and inclusion. We're trying to bring people up with programs that are training students, that are bringing them into medical school and bringing them from medical school into training programs, summer course, committees that help bring underrepresented minorities into residency in radiation oncology. And then during the residency, obviously, making everyone aware of the incredible value and the importance of having diverse voices at a table. And that really is what we need throughout all of medicine at all levels.
So Otis, there were a few stars that had come into alignment when I begged you to please come up here and join us in Baltimore. One of them was that, the next generation up and coming. So public health is the most popular major for undergraduates at Johns Hopkins. Public health has been for several years. The earnest young people who want to make a difference. They want to embrace diversity and overcome inequities when they can. I know what kind of teacher you are, and I love the idea of a Bloomberg Distinguished Professor so that you'd have access to these undergraduates as well as medical students and everyone else. Where do you see this going? Are we on the verge of delivering a cohort of people who will solve this problem?
I am very optimistic, not only in medicine, but even socially. In the protests after the tragic murder of George Floyd, very diverse groups of young people, Black, white, Indian, Hispanic, Asian, very diverse. When I look at our medical school population, I'll even go to all the doctors under the age of 40. I think they are much more in tune to these social issues than those of us who are, starting to get toward the end of our careers. So I have great hope. I also think we have to look beyond doctors. We need to look into the hospital systems ourselves. Nurse practitioners, physicians, assistants, the whole clinic environment has got to evolve and change with time. And I'm hopeful, and I see that. My great concern is still access to everybody and access to the funds to provide the navigation so that people who need a little help getting through our system can actually have that help to get through our system.
So with that, we're at 45 minutes, which was our time, which is good. We've had one question so far, and I would invite anyone else with a question to contribute. This one comes from Katie Fialis, and it was interesting. Notice that she was entering sort of right where you ended up with is in the face of some of these social determinants of health that limit the people's ability to engage with healthcare on a bilateral way. Does patient navigation help? Is that what we need? Is patient navigators, case managers, people who are attentive, have creative solutions to the financial toxicity, to the transportation issues, presumably someday to stress-reducing tactics, to better food. Will that work? Is that what we need to do at this point?
Yes, and there's social workers, and we need social workers. God bless social workers. Then there's nursing. Yes. Yeah. Then there's nursing, which is its own profession. And then the other profession that we need is navigation. And these are usually going to be nurses or peers, and their job is to guide people through the hospital system. Realize, sometimes be the big buddy and actually be able to say to the social worker, Mrs. X has these problems and we really need to address them. Why don't you ask her about these problems? Because she's not telling you, but she's telling me. So yes, navigation is an incredibly important thing. You know, we've done a great deal toward access to care and making sure people have insurance. Although some of your statistics indicate people are starting to lose that because of unemployment and other things, but we need to be able to have a system that people can actually use. It's not just enough to provide access, but to provide the ability to utilize that access in an intelligent way.
So to take there's another question I'm going to get to for Akila, because I think she'll have a good answer. But you know, some of the early versions of the modern tactics for patient navigation in cancer came from experiences at the Harlem Hospital, where they made very easy access to mammography. And these poor women would say, okay, you have an abnormal mammogram. They said, what am I supposed to do next? They said, well, you should get that taken care of, or something equally useless. And so what they needed to build was navigation so they could get to the next step, a biopsy, the right evaluation. And you've emphasized several times, this time and the last time, that one of the symptoms that we see of health inequities when things aren't working out well is that people are diagnosed with late stage. We're missing the opportunity to deliver a mammogram and have that mammogram promptly and responsibly acted upon by the healthcare system. And all these things end up being barriers to it. What is your view in these early phases? If we're going to deliver screening and early detection, all of these things will be a barrier unless we can use navigation to overcome it, I guess.
Absolutely. And as you know, Dr. Brawley pointed out earlier, and what you alluded to, it's that comfort of knowing where to go next and how to get that treatment delivered. And I think, you know, being inside the healthcare system, sometimes we have to navigate and be proponents for either your family or friends, and that can be difficult too. And so being on the outside of that, you can only imagine how overwhelming it can feel to a patient not knowing how to utilize that healthcare system. So this area of professionalism in navigation is so important as we develop that, so that we can guide people. And we've had some conversations this week on this and how we may build that within our system. And part of that sometimes has to be hand-holding also, and coming into the hospital with them and guiding them through their appointments and their clinics, and then following up to make sure that we don't lose them in that process, so that they know that they have to come back for X, Y, and Z, and just kind of lay that out for them. And that's just so important to be able to complete that treatment, especially when we talk about extended treatments like what Dr. Viswanathan does with radiation oncology, and that they don't miss any of those appointments.
So Akila, somebody responded particularly well to the poignant story you talked about at the African American History Museum vis-a-vis, written legends versus a recorded voice that would introduce you to the exhibits. And so they were asking, are we using other tools, recorded voice, film, other tools, as we educate patients regarding their treatment, how to be compliant with it? We do a lot of patient education. Are we using the right suite of tools? And I guess the other question is, are we creating unintentionally other barriers? If we say, oh, go to this website or something, that may not be that easy to do, depending on what your financial and other circumstances are. So what about the education tools we have? Are they good enough? Can we improve them?
What a great question. And thank you for writing that, whoever wrote that. I think we can never do enough. We always need to be vigilant about this. Of course, we try, we have videos, we have, ways of teaching people. We meet with people in person, we do telemedicine, we have, the really important point that Dr. Brawley brought up about navigators. That's really their whole role is translation into the level of understanding where that person, that patient is in terms of their needs. So, making sure they know how to navigate from, one building to another is one aspect, but just navigating a conversation is another, because it's not just the written word, it's also, the language that we use is really complicated, and trying to even simplify it for all of us, it can sometimes be a challenge. And so a navigator is absolutely essential to make this, word meaningful to the patient. So we're trying, we do have some systems, but again, our whole world needs to always be vigilant that the web, not everybody has a computer, not everybody can read the web. YouTube is ubiquitous on our cell phones. Not everybody has a cell phone. I always say, if we can solve a problem in Baltimore with the population and the diversity that we have, we've solved it for the world.
So Otis, there's an ephemeral concept in sort of public health, which is the teachable moment. And cancer screening, which you're one of the great experts in, cancer screening is replete with these stories. When Betty Ford had breast cancer, mammography went up. When Nancy Reagan had breast cancer, mammography briefly went up. When Katie Couric had a colonoscopy on live television, colorectal cancer screening went up. I can still remember seeing the late, great Elijah Cummings giving a spellbinder of a speech where he said, you need to get PSA tested, and PSA test went up. We've thought a lot about this, as you know, and in your plans to think about colorectal cancer screening, which we're beginning to do better at across the country. It's one of the quiet success stories if we can build on it. And trying to, how does that get messaged perfectly? And then out of the blue, Chadwick Boseman tragically dies of a colorectal cancer. And this was noticed by many people around the country. And so all of a sudden it appears to be a teachable moment. A diagnosis of cancer is a teachable moment to get someone to stop smoking. How many of these teachable, are we exploiting those? Can we find them? Can we drive this business?
Yeah, we are not exploiting them correctly. Sometimes they're mis-exploited. By the way, whenever a famous quarterback goes down because of a knee injury and they announce he's going to have an MRI of his knee tomorrow, MRIs of the knee go up in that city for the next 2 weeks. We need to approach screening in a rational manner. I wish we could get people into a program of screening where people actually went to a place and they got all the screening tests that they should get, instead of what happens so frequently is people stress, get a PSA, and don't talk about colorectal cancer. Colorectal cancer is near and dear to me because I've actually calculated how many lives we could save if we went from the 60% or so of people who should be getting it now, up to just 80%. There's a lot of lives that could be saved.
Well, one of the things about that, that's good news in the space. Although it was difficult for a number of years, it ran the program in Baltimore City involving screening the uninsured. We did prostate cancer, colorectal cancer. University of Maryland did breast cancer and cervical cancer. But one of the striking things that we discovered is when people would come to us and take us up on the screening, it was more often than, I think it was like 2/3 of the time, first time they had their blood pressure checked. So
Yeah.
what you're talking about is a coordinated benefit of health promotion, and perhaps even then a teachable moment for healthy lifestyle, which will aid in health promotion.
Absolutely, absolutely.
So with that, we come to a close in this second session. We've talked about access to care. Now we've talked about social determinants of health, exploring many of the facets of it and how they contribute to health inequities, and how we hope that they can be progressively overcome, perhaps by our generation, and certainly I'm optimistic at least the next generation. So we have one more in this series, and we look forward to having all of you back with us. By the way, if you have questions outside of this, because you think about them for a while, don't hesitate to jot them down and throw them at us later. So thank you all very, very much for joining us yet again.